As an interventional cardiologist, I deal with cardiovascular disease every day. And so we'll talk a little bit about this, and feel free to stop me to ask any questions that you may have. This is really meant to be a very interactive session. So the title of the talk, Empowering Heart Health, Innovations and Risk Factor Management in Cardiovascular Disease. Great. Looking for all set. Awesome. And we're going to move on here. So we're just going to give you an introduction and overview. So we really want to make sure we educate all of you, our patients, our students, really making sure that you understand what cardiovascular health means and how do we focus on prevention. That's really important, whether it's what's called primary prevention or secondary prevention. Primary prevention is a term that we use to prevent a first coronary event. I say coronary, but really cardiovascular, that we're trying to prevent a stroke, we're trying to prevent lower extremity peripheral arterial disease, we're trying to prevent a heart attack. But then in those patients that have had a heart attack, not to despair, there are many things that we can do now that can prevent a patient from developing a secondary event. So that's called secondary risk prevention. And fortunately, the things that we do in terms of primary prevention are also very applicable in terms of secondary prevention. So we're going to focus today on risk factors. And you are all well-read people, I'm sure. We have access to the internet, social media. And so you may have many questions about risk factors that I don't review here. And so feel free to chime in as we go through this conversation. And then we'll make sure to review interventional cardiology treatments. I think that will be a big part of what I'll be able to offer to you as an interventional cardiologist, the opportunity to talk to you about innovations in this field, that when a patient has a heart attack, what we can do to alleviate the obstruction of the artery and relieve the symptoms. And then I want to really make sure we integrate it in terms of this idea of community wellness engagement. This program is just really remarkable. I've been at UC Davis now for 8 years, and I'm ashamed to say that this is my first time actually physically being here. I can say that I have referred patients here of mine, and it's such a wonderful program because it is really important that when we think about cardiovascular health, that we are interfacing with the community, that we're engaging with the community, because this unfortunately is a very big problem. And we need to really work with the people, our members of our community, our family, to make sure we're doing all that we can so that we are preventing a primary event or a secondary event. So we're going to understand now cardiovascular disease, or that's my hope for you as we discuss this. Why does cardiovascular health matter? Well, unfortunately, globally, it's the #1 killer. Globally. That wasn't always the case maybe 50 years ago, but now there is a spread of wealth across nations that allows us to free access to food that is processed to some degree. And that processed food is not necessarily good for us. And we'll talk a little bit about that. And then this idea of a sedentary lifestyle, we really need to combat that. And that's why all of you are here, which is wonderful, that you realize that being around others, socially engaged, and focused on fitness is such a huge thing towards preventing cardiovascular disease. And a heart attack. Can you believe still in the current era with all the technology that we have that a heart attack happens every 40 seconds? So we could do the math here during this conversation. How many patients' lives are affected in such a dramatic way by cardiovascular disease? It is really dramatic. I sometimes think about a patient coming into the hospital with a heart attack. With the innovations we have in interventional cardiology, we're able to treat that problem with a stent, for example, and they're able to go home the next day. But it's a disservice if we say that go home and just carry on with your behaviors, because of the fact that this is a life-changing event that we have to make sure that we are incorporating in every aspect of our lives moving forward, the key features to make sure it doesn't happen again. so that we can have longevity. Another important part to this is prevention and education. And so while cardiovascular disease is a global disease, there's still so much more that can be done in terms of education to our community to make sure we're doing all things possible to prevent cardiovascular disease from recurring. For example, if it affects a family member, a parent, we want to make sure that we're doing all that we can to not only impact the life of that patient, but also that family. We want to build good, healthy habits that impact generations to come, including the children and grandchildren. It's really important to remember that aspect. And that's why education is so important as well as prevention. So when we think about cardiovascular disease, there are many different aspects to this. A lot of times when we talk about cardiovascular disease, we're focused on coronary artery disease or coronary atherosclerosis. That refers to the set of events that take place where a narrowing develops in an artery supplying the muscle of the heart. But there are more aspects to this, and they're interrelated. That patients can also have arrhythmias. Arrhythmias refer to the fact that the heart has coordinated electromechanical activity, that for the heart to be able to function, it has to be in sync in terms of the electrical system. And sometimes that electrical system can go awry, and patients can have annoying arrhythmias like atrial fibrillation that can have a really important impact in patients' lives to more life-threatening arrhythmias like ventricular tachycardia or ventricular fibrillation. And how is coronary artery disease related to this? Unfortunately, many patients are at home when they suffer a heart attack, a myocardial infarction. And because of the fact that there is a lot of heart muscle not getting adequate blood supply, what can happen is these dangerous arrhythmias like ventricular tachycardia and ventricular fibrillation, and a patient will have a cardiac arrest. A patient will have a cardiac arrest. And that's how it might be related. But there are plenty of patients that have also cardiomyopathies. Cardiomyopathies refer to abnormalities in the heart muscle. So they can develop conditions like hypertrophic cardiomyopathy. Patients can also develop what's called ischemic cardiomyopathy. So because they have blocked arteries and they've had heart attacks, the heart muscle gets weakened. But the point I'm trying to make is that when a patient suffers a sudden cardiac arrest, it doesn't necessarily mean they have a blocked artery. They could have a condition like hypertrophic cardiomyopathy. In particular, we notice among our young athletes, the most common cause of sudden cardiac death is hypertrophic cardiomyopathy. So this is something that we really try to screen for. The other part to this is valvular disorders. That among the most common valvular disorders is what's called aortic stenosis. That's a narrowing of the aortic valve. That's the last valve that blood needs to travel through before it exits the heart. And so patients can develop calcific degeneration where calcium builds up on the aortic valve, and because of that, it doesn't open properly. But patients can also have leakage of valves too, like mitral regurgitation, which is arguably the most common or second most common valvular heart disease. And so when we think about cardiovascular disease, we think about coronary artery disease, we think about arrhythmias, we think about heart failure and valvular disease disorders, but there's more than just that. But this is, I think, an important point to make, that when a patient has a cardiac arrest, for example, that doesn't necessarily mean they have coronary artery disease. And so I just want you to be aware of that concept, that cardiovascular disease, unfortunately, has many manifestations. Okay, great. Let's talk about risk factors for cardiovascular disease. So I think you're familiar with these. So high blood pressure is a concern, high blood pressure, cholesterol, smoking, diabetes, obesity. Sometimes we don't like to use that term. We'll use the term adiposity-based chronic disease. Maybe we can talk about that later. And then inactivity, a sedentary lifestyle. So these are just some examples of risk factors. Are anyone in the audience, are you aware of other risk factors that you'd like to mention These are some basic ones. I'd like to address other risk factors maybe you're concerned about. If you're, what was that?
Smoking.
I'm sorry.
Smoking.
Smoking, right. Smoking is a really big one here. We do have that listed here. Smoking, no problem. No problem. It's not a quiz, it's not a test. So it's a really big one. But questions come up, for example, about stress. I have a lot of stress in my life, doc. Is this a reason why I developed the heart attack? And so I think that's a difficult question to answer, because when a patient is stressed, sometimes they make decisions that are not the most heart healthy. For example, when they're stressed, they're not eating heart healthy foods. They're not exercising. They are maybe drinking sugary drinks. So there are different aspects to that. But we do know that coronary artery disease, blockages in the arteries of the heart, is very much tied to inflammation. And we know that when a patient is having stress, they activate a stress response. And so there certainly is inflammation that takes place associated with it. So there may be a direct effect. And then the question also comes up within our cardiology literature about a patient having cardiovascular disease. Is it a single risk factor that caused a patient to have that cardiovascular event, or was it multiple risk factors? We don't know the answer to that yet, but it probably is interplay between multiple risk factors that results in an event in a given patient. But certainly there are situations where we see there's a more dominant feature where, for example, smoking, as you mentioned, where a patient may be doing all the right things, but they are smoking. And that seems to be the obvious risk factor for them developing cardiovascular disease, maybe earlier than you expect, maybe in their 30s or 40s, let's say. Yes.
Preeclampsia is a recent.
Yeah, so preeclampsia is tied into this, in that we see that preeclampsia or eclampsia can be a sign of cardiovascular disease down the road. And so we often see that tie related to hypertension, that when patients have preeclampsia or eclampsia, we see that they're not doomed to having hypertension, but they're at higher risk to having hypertension. And so we really know as physicians, providers, that when we have that history, we should really pay attention to that patient to do all that we can to make sure they don't develop overt hypertension. Same thing with gestational diabetes. During pregnancy, you can develop diabetes. We know that that might be a risk factor for developing outright diabetes later in life. So these are really important examples that you point out. And just as I put as a caveat earlier on, I'm trying to list the major ones, but invariably there's a lot that we are not necessarily reviewing, and there's a lot of active investigation in this area. That in fact, what we're seeing is that all of us have stem cells. Stem cells are kind of our early precursor to cells that differentiate into, let's say, heart cells or brain cells. And we see that in that process of proliferation of the cells, meaning multiplication of the cells, that can go awry sometimes. And there can be processes that can develop that can lead to cardiovascular disease. So we're learning about that as a possibility as well, too. Other things, again, are this idea of prevention and management, that we really want to make sure that we're living what's called a therapeutic lifestyle, What does that mean? Well, we're going to get into it, but a therapeutic lifestyle refers to the idea that we're eating a heart-healthy diet and we're exercising regularly. And the reason why we call it a therapeutic lifestyle is that it's just as important as medications. It really is just as important, if not more important, in certain patients. So that's why we use the term therapeutic lifestyle, to really get across the point that it is a therapy to prevent a patient from developing cardiovascular disease. So again, I applaud all of you for being here and participating in the program, because you are working towards this therapeutic lifestyle. And the role of public health. Well, that's why I'm here. That's why you're here. That's why we have a great program like this available through Sac State University, that we really want to make sure that we're tackling this not patient by patient, but in terms of a whole population, our population here in Sacramento, working as a community, as a family, to help others around us. Then we have these non-modifiable risk factors. patient has a heart attack at age 40 and they say, well, doc, what can I do to prevent myself from having cardiovascular disease? And so we talk about if they're smoking, to quit the smoking. If they're drinking heavy alcohol, we want to encourage them to decrease that. But there's certain things that we can't control. A part of living, part of being a human being is aging. And we know that as we age, that unfortunately we get a lifetime of our Western diet, for example, and that exposes us to the possibility of really developing atherosclerosis. That's a process that we refer to of narrowing or plaque buildup within the arteries of the heart. And so we can't fight our age. We have to live with our age. But I think it just emphasizes the idea that we have to be even more aggressive as we get older in terms of the exercise that we need to do and even diet as well. Because of the fact that, for example, as we get older, we do develop insulin resistance. It is part of aging that our body doesn't respond to the insulin that we produce to bring down the blood sugars. So as we get older, we might see something called a hemoglobin A1C, a marker of what our blood sugars have been for the 3 months prior, go up over time. And so again, it emphasizes the idea that to battle this aging process, then we're going to do what we can in terms of what's under our control. And what's under our control, again, is the concept of diet and exercise. There's also gender differences that men have a higher risk at younger ages of heart disease, but women catch up when they are postmenopausal after menopause. And so for a long time, we were really focused on heart disease being a problem of men, but that is completely incorrect, as you know. It's a disease that is blind to gender or race, that affects everyone. And so we have to make sure we're addressing it in our community. We're addressing it for everyone. Another key component here is genetics and family history. And so we want to pay attention to our family. If we have a family member that develops a coronary event, develops a heart attack at an early age, we want to be proactive. We want to see a doctor to say, hey, look, my mom had a heart attack at age, let's say 52. What can I do to prevent myself from having a heart attack? So it's really important you have those conversations, those tough conversations sometimes to have with our primary care doctor, or maybe we push that primary care doctor to put a referral to a cardiologist, for example. And then how do we manage these non-modifiable risk factors? I think, again, what we talked about earlier, that we need to make sure we have an awareness of them, in that we talked about the hemoglobin A1C, our risk for having diabetes. So if we're aware of this, then we can make interventions to minimize the effect of the aging process in terms of cardiovascular disease. And then the modifiable risk factors, the ones that we have under our control. And so we're really focused on adjusting our diet, increasing our physical activity, and if we're smoking, making sure that we're not doing that. Also reducing our alcohol, limiting our alcohol, and also addressing stress management. And so you may have heard in the past this idea of, okay, alcohol is good for my heart. If I drink a glass of wine, that's going to really help my heart. And so there may be some data to suggest that in terms of coronary artery disease, we don't find that to be beneficial as far as atrial fibrillation, for example, which is a very common arrhythmia, that we know that with alcohol intake, it has a direct effect on the muscles of the heart and can result in arrhythmia. So as cardiologists, we're never telling a patient, hey, you're not drinking, why don't you start drinking a glass of wine every day? Okay? There are just so many implications related to it, not only related to our heart health, but also related to our liver and other organs of the body. In fact, it's a little bit controversial, this recommendation that generally will say for a male, it's okay to do 2 servings of alcohol per day, and for a woman, that's okay to do 1 serving of alcohol per day. I don't want to get too much into health policy, but it's been really controversial that there have been some efforts to fund research to really determine if that's appropriate. Some of the funding has not been available. We've not been able to see that data as of late. But I think my advice to you would be to minimize alcohol in general. Yes.
Most of the great, that's really the benefit Making of alcohol more the grape than the.
Yeah, so this relates to this concept of antioxidant properties. So we'll often recommend that a patient eat a bowl of blueberries, strawberries. With the grapes, it relates to that idea of antioxidant properties. So when we think about the pathophysiology of atherosclerosis or coronary artery disease, what we find is that there's what's called reactive oxygen species that develop that basically there's these molecules that actually result in atherosclerosis and cause damage. And so by having antioxidants that scavenge these reactive oxygen species, we're able to mitigate that damage, reduce that damage. And so that's the idea behind alcohol or grapes and why we encourage patients to think about berries in particular as having good antioxidant properties. And that's the mechanism by which they're beneficial. And then the other part is the rural healthcare provider. We talked about this already briefly, that if we have a family history of heart disease, that we want to make sure that we're reaching out to our healthcare provider to ask any questions we have. That's why I'm here, is that I want to make sure that you're aware that we as healthcare practitioners care about you, want to get out into the community, we care about where we live and want you to utilize people around you that have spent time studying this area and are really dedicated to having good cardiovascular health. Okay. So we'll talk a little about hypertension and heart disease. That's a really important concept related to the idea that hypertension causes damage to the blood vessels and raises the risk of not only a heart attack, but also stroke and heart failure. That the number one risk factor for stroke is hypertension, high blood pressure. So it's really important. We're working towards controlling our blood pressure. I won't step too far away from the microphone. Sorry about that. And so we want to really make sure that our blood pressure is at a goal of less than 130 or 80 for most patients that have had heart disease. That if you've had a heart attack or stroke, your goal blood pressure is less than 130 over 80. We had new guidelines that were published by the American College of Cardiology and American Heart Association. I didn't see in my own experience too much in the news about these new publications. I think in large part because there wasn't anything too different from what we were doing before. That 130 or 80 goal has been something that we've been really moving towards. We had been concerned about whether this applies to patients of all ages, particularly as patients get older into their 80s and 90s. We really worry about the impact of being on blood pressure medications and how one could have a more dramatic effect. But we're seeing more and more from clinical trials that focusing even as we get older on this blood pressure goal of 130 or 80 is pretty reasonable. But I don't want you to go home and say, well, my blood pressure has to be 130 or 80. It really does need to be discussed with your healthcare practitioner what your goal is, because we have exceptions to that rule. That we won't necessarily start a patient on a blood pressure medication if the blood pressure is in the 140s, for example. We have certain ways that we want you to check your blood pressure, and we want to check your blood pressure more than one time before we give you this diagnosis and start one on medications. And we always like to begin with diet and exercise. And so when we think about, again, about hypertension, it is damaging the blood vessel throughout the body. It can damage the blood vessel in the arteries of the eyes. It can damage the blood vessels in the brain, as we've talked about. And also damage the blood vessels in our arms and our legs as well, too. And so,
Question.
oh yes, I'm sorry.
I'm curious about this concept of having a broken heart. You know, some people, as we get older, we don't handle grief very easily. If you have some shock or something, you believe in a broken heart. Would it be better to have a bowl of raspberries or cherries instead of a glass of wine? Or what is the difference is you
Yeah,
can take yourself and help yourself.
So the question is related to this concept of a broken heart. What is a broken heart, and what can one do to prevent themselves from developing the condition? Should they drink a little bit of alcohol? Should they eat these berries? And so broken heart syndrome refers to a condition called stress-induced cardiomyopathy. That would be a medical term. From Japan, we learned to call it Takotsubo cardiomyopathy. And so this is a form of cardiovascular disease where it falls into the category of heart failure. And so what happens is that when a patient is exposed to a stress, it doesn't necessarily have to be a bad stress, that it's well known and documented that we've had patients that would win the lottery. And because of the excitement of winning the lottery, what would happen is that the heart muscle would get weakened. And patient would develop the condition of heart failure where the heart is not contracting as well. And so in that situation, when we think about the different causes of heart failure, the prognosis is relatively good in the sense that patients are quite frequently able to recover from the condition. Part of it may be time. Another part to it may also be being put on a set of medications that have been well studied in heart failure that can make the heart function better. But we don't have specific data to say to you, well, eating berries or doing or drinking a glass of wine will prevent this. Actually, we don't really have good strategies to necessarily prevent it. Fortunately, it's not a condition that affects a large part of the population, but still it affects our population, and so it's important. So I would say to you, my best advice to you, if you're concerned about a condition like this, is to really train your body to be the healthiest version of itself that it can be, which again refers to the idea of diet and exercise. That's why you're here in this program. And I think if you focus on that, then your body will take care of itself, and hopefully you won't have that type of condition. But it's a good example of how the heart and mind and body are connected, because of the fact that very clearly a severe stress causes the heart muscle to get weakened. And so again, there's no doubt about it that we need to be holistic in our care, that we can't just be single track minded and just focus on the heart. We have to treat the whole patient. Yeah, my pleasure. So awareness, we keep ending every slide with the idea of awareness. Yes, yes.
The broken heart syndrome is there progression like there is with heart failure?
Yeah, that's also a really great question that many patients can have recurrence. So we have some patients where they'll develop the condition and it can be catastrophic to the point that they need a support device. So they need a device that needs to be implanted in the heart to support them through the event. And then more times than not, patients are able to recover. And then they're placed on these medications I had just mentioned to you, typical of heart failure, to help the heart muscle get stronger. Sometimes these medications aren't continued, and we see a patient have another stressful event, and they can have another clinical deterioration. And so the practice of most cardiologists would be to be on the therapy over the long term. We do have specific studies looking at this idea of heart failure with improved ejection fraction. So this idea that a patient had a weakened heart muscle measured by what's called an ejection fraction, and they had recovery. And is it a good idea to stop their medications in that scenario? And the studies that we have in that scenario suggest it's better to stay on the medications, that these patients may very well develop a heart failure again. And so to prevent that, it's a good idea. But I focus on the medications, but also the rehab and all that aspect too. The studies it's more easy to focus on medication in a clinical trial like that, but no doubt being in the right program makes a huge difference. Okay. So diabetes and cardiovascular risk. Sorry, one second here. I'm so sorry. I can't escape the hospital. Okay, diabetes and cardiovascular risk. So diabetes is very much a big part of cardiovascular disease. And the idea that when we talk about plaque buildup, what's depositing in the artery wall is blood sugar and also cholesterol. And so we know when the blood sugars are really high, what happens is that it modifies the cholesterol circulating through the bloodstream and makes it more likely for it to deposit in the vessel wall. So we know that controlling blood sugars is really critical to the idea of preventing atherosclerosis when we think about the exact mechanism. So it's really important that way, that again, this high blood glucose damages what's called the endothelium, which is a layer that surrounds a blood vessel wall, this living, breathing thing, if you will, the endothelium. And again, it can accelerate the process of developing blockages. It also puts us at higher risk for cardiovascular disease. And so it's really important that we focus on management. But believe it or not, while it is important to take insulin, for example, to bring down our blood sugars, that not all medications are created equal when you think about diabetes. That only recently have we found medications that treat diabetes and prevent cardiovascular disease. That's really been amazing because until recently, we were using insulin to help control blood sugar. And the idea was that, okay, controlling blood sugar is really important, but we're not finding that's preventing heart attacks. So we have these medications like semaglutide, you may have heard Ozempic, Wegovy. These are medications now that not only treat diabetes, but they can prevent cardiovascular disease. And then you may have heard a medication called Jardiance, which is part of a class of medications called sodium glucose coenzyme 2 inhibitors, gosh, a mouthful, that treat diabetes and they also treat cardiovascular disease. So it's a really exciting era that we have these new medications available that treat both issues. And not only that, these medications can be very beneficial in terms of preventing obesity. They can also be very beneficial in terms of preventing kidney disease. So really important that we have these options available to patients that treat diabetes, kidney disease, cardiovascular disease. And so now as physicians, we're really recognizing that as a cardiologist, when we're starting a patient on a medication, that we're not necessarily focused on the heart alone. We're thinking about, well, is there a benefit for the kidneys, for example, in that patient that also has maybe kidney disease related to the diabetes? So again, it's really exciting that we cannot be in our silo as a cardiologist, that we really need to think about the patient as a whole.
2 questions, Doctor.
Yes.
Can genetics also be a risk factor?
Yeah, so we really want to emphasize that that genetics certainly can be a risk factor. There's also this concept of epigenetics. So when we think about genetics in general, and I think most people in the room will agree with this understanding, we think about having a disorder with a gene that results in a condition. But we also realize that we have what are called epigenetic components to this, that it's not only the gene, but it's how that gene and the patient interacts with the environment. That the patient may have a mutation, let's say, in a gene, but it doesn't manifest itself until a patient smokes. And so it's interconnected to some degree. So that's what we refer to epigenetics, the idea of epidemiology, what a patient is exposed to. And so I think this really emphasizes, it gets me excited about the idea that, yes, sometimes we can't control our genetics to some degree, but there are aspects that we can control to make our genes less important if they are going to commit us towards a pathway of heart disease, for example.
Second question was explain ejection fraction.
Yeah, ejection fraction is not something I think we need to emphasize too much here today. It's a measure of how well our heart functions. So it's a number that can be measured with an ultrasound of the heart that can be done at any hospital throughout the world. And so then it allows us to speak the same language when we're talking about the function of a heart. It allows us to be able to compare. But not something that I want you to worry about. I don't think you need to ask your doctor, hey, what's my ejection fraction? It can be very relevant in a given patient, but may not be relevant in other patients. We want to emphasize more of the things we talked about being the healthiest version of yourself that you can be, focused on this therapeutic lifestyle. And now we're here at smoking and vascular health. And so when we think about smoking, we see that there can be a very direct effect with smoking. And when we think about the pathobiology, what we're seeing at the molecular level is that nicotine results in what's called oxidative stress. We talked about that earlier, or had that question related to the wine, that we have these reactive oxygen species that go out and they start damaging the blood vessel wall. And so nicotine is directly involved in that process. It creates these reactive oxygen species that damage the blood vessel wall, which is why it's so important to stay away from it. And also very important to make sure that we're not getting secondhand smoke. Sorry. Yes. That's a really good question. So yes, that they're also affected by that as well. The nicotine itself is directly involved, whether it's transdermal or it's a gum. But we're using these techniques to wean a patient off of the addictive potential of the nicotine.
What was the question? I didn't hear.
Oh, I'm sorry. The question was related to the idea, is it okay to do a transdermal patch? Does it have the same effect as smoking cigarettes?
Thank you.
Okay, yeah, no problem. And so the answer to that was that yes, it's the nicotine. And the concept though was that while we want to avoid nicotine completely, the nicotine in these transdermal patches is being released very slowly as we cut down the amount of milligrams associated with it, which can be really beneficial to wean off of the nicotine and the tobacco. Okay, lifestyle and prevention strategies. Well, we've talked a little bit about this already. And so when we talk about heart healthy diets, we're really focused on this concept of a Mediterranean diet. But what does that mean? What is a Mediterranean diet? What is a heart healthy diet? And so when we have these discussions about what a Mediterranean heart healthy diet is, I think what's really important is to be plant-based. That we're not telling you that you need to be a vegetarian, but you do want, if someone was to sit on your shoulder for 24 hours and kind of watch you eat, you want them to be left with the impression that plants are a big part of your diet. And we also want to avoid processed red meat. We're not saying that you can't eat red meat, but we want to minimize that. Why processed red meat? Well, that sausage, that ground meat, the cold cuts, it has a lot of saturated and trans fatty acids, but really saturated fat. We want to try to minimize that. It's not very heart healthy. We want to focus more on lean meats like turkey breast or chicken breast in particular. But what's really beneficial is fish, oily fish, like salmon, tuna, mackerel, sardines. And then I got a question, well, is tuna in a can okay? Well, tuna in a can's okay, but it would be better to get it fresh if you can. I think that would be our recommendation. And we encourage the preparation to be more grilled. We want to grill our foods as much as we can. So we're talking about meats in particular. But we want to do 2 servings of fish a week. Yes, we have a question.
You mentioned tuna in a can, not so much, but most sardines that I know that can.
Yeah, right. So yeah, so we're not having you sweat it too much. But if you had options about different fish, then it may be better to think about the fresh fish. But yeah, right. Generally, we think that's right. But don't sweat it. That if you have canned sardines or tuna, that's also heart healthy. But there may be more benefit if we focus on more fresh food. And so when we're talking about being plant-based, specifically, we want you to think about lentils, beans, legumes. Those are also really important. I say to patients that you need to think about 3 to 5 servings per day. So that's a lot. That's like a plate of salad and then maybe a half salad, for example, to get to maybe 3 servings. So we really want to make sure that's a big part of this, is that you're getting plenty of vegetables. Also, another part to this is nuts. We think that nuts are very heart healthy, but not all nuts are created equal. So we're not talking about cashews, we're not talking about pecans, we're talking more about almonds and walnuts. Almonds and walnuts, okay? So I got a question the other day about pecans. Pecans are similar to walnuts. Do they have a benefit? So the reality is of our world is that to be able to make recommendations, they're in large part based on clinical trials. And so California walnut farmers got together and they funded good trials demonstrating that walnuts are beneficial, as well as the almond farmers in our state. So they got together and they funded these good studies, high quality studies showing it's beneficial. I haven't yet seen the California pecan farmers get together to publish that data, but you wonder, you think you probably could extrapolate to some degree. So that's why we're really emphasizing almonds and walnuts, because of the fact that there's good data to support it. we get questions related to the fact, well, is almond milk a good alternative to raw almonds? And then we talk about the idea of process. And I don't want to give anyone here a hard time if they really do prefer almond milk to raw almonds, but you can imagine might be better to focus on the raw almonds. But getting almonds into your diet is really great. And we talk about four handfuls per week of almonds or walnuts. Okay, almonds or walnuts. Yes.
Are there particular types of nuts that should be avoided?
Yeah, I'm not aware of any particular nuts where I say to a patient, well, you definitely need to avoid this type of nut. I'm more of the sort that I like to say to a patient, here's the data. We have good clinical trials to support these nuts. So if you want to eat peanuts, you can, but you may not get the same benefit that you would with almonds or walnuts. And I'm not aware of any data of any specific nut having an adverse effect in terms of cardiovascular health. Yes.
They talk about Brazil nuts. I mean, don't they? Brazil nuts?
Hazelnuts?
No, Brazil.
Oh, Brazil nuts. I'm not, again, I get a lot of questions related to what you're mentioning, and it's hard to be able to answer all the specific nuts. And so then I come again to this idea that we have good studies that were performed in our country demonstrating these specific nuts. I don't know the exact contents of the nuts, for example, you mentioned Brazilian nuts, you mentioned, to be able to say for sure, but it's a monounsaturated fat that makes these nuts heart healthy. Monounsaturated fat. Okay. Another part to this is that we're not telling you that you need to pursue veganism or be a vegetarian. And so a lot of times patients think that we're as a cardiology community telling patients to do that. If you choose to do that, that's great. No problem in terms of a cardiovascular point of view. We just get worried about the lack of calcium in a vegan diet. And so that's an important part there, is that it can result in what's called sarcopenia and also hypocalcemia, low calcium levels. And so we want to make sure that if one does choose that type of diet, that they are getting all the nutrients that they need. But I think the big part to the Mediterranean diet is this idea of vegetables, avoiding processed red meats, thinking about nuts, and another category we haven't talked about is whole grains. Whole grains are also really important. And so when we're thinking about whole grains, we're thinking about things like having a bowl of oatmeal every day. So the steel cut oats in particular, not the instant Quaker oats that you can microwave for like 10 seconds and get a meal, just because it doesn't have all the nutrients. Yeah, exactly. You're wording out process. We worry that there's a lack of nutrients in that type of scenario. We're not saying that you need to eat rice, but we recommend brown rice being better than white rice. We're not telling you that you need to eat tortillas, but whole grain would be better compared to white, and same thing with bread. Quinoa is a really good option as well too. Quinoa is a really good whole grain. We have a question here.
My dad, he's terrible at staying away. Would you recommend like more lean red meats, like lamb or grass-fed beef?
Yeah, I think that can be an option, is to try to focus more on the leaner meats or the leaner parts of these meats. But I think that one needs to ask themselves, how important is it to get the red meat versus their cardiovascular health? I think that's always a fundamental question. And as a cardiologist, we cannot make a decision for the patient. The patient comes to see us, we offer suggestions, we respect your autonomy. We respect your ability to make decisions on your own. And so for a given person, this comes up all the time. The patient says, no, doc, I am not giving up that red meat, for example. And we respect that. But we just explain that there may be a higher risk then in doing that. And if you're okay with that, we respect that. Yes.
Heard that higher quality red meat can be difficult. Like,
Yeah, so
you know,
there are certain,
like much higher quality red meats can be just as healthy as the chicken or something.
it's really great questions. Again, I come back to some of these trials, these clinical trials that have investigated that you may be very well correct, but as a physician, we adjudicate or make our decisions based on these clinical trials because it's our best evidence. I don't want to sound like a snob in that way that, okay, well, if it doesn't have any scientific evidence, I'm going to ignore it. But we have to have that sort of basis to be able to make our recommendations to a patient. But yes, there are certainly certain types of red meat that can be very high in omega-3 fatty acids. That is no, you're right, and maybe just as beneficial, maybe as the fish that we talked about. It's just we don't have clear-cut clinical trials to say, okay, if you eat that red meat that has very high omega-3 fatty acid, that it's going to be just as beneficial as the salmon, for example.
Isn't red meat also connected to inflammation, considered an inflammatory food?
Yeah, so that gets into another aspect of care is this concept of inflammation and diet. That we're seeing more and more data about the fact that there can be food choices that we can make that can certainly impart less inflammation in our body, and that can be associated with less risk of cardiovascular disease. I have to say that for me as a cardiologist, I haven't seen robust data where that's necessarily prime time, or I'm saying to a patient, let's do a test to see how much inflammation is your body based on what you're eating to make a decision about how well a patient's doing. Yes, we have a question here.
Just wondered, is there any benefit to eating organic like chicken as opposed to not organic?
Yeah, I think that we're hard pressed to say clear cut cardiovascular wise. I think that certainly the advantage is that there's less pesticides and things of that nature, and that can be beneficial, maybe aside from the heart, other organs of our body as well, too. But I think that when I get that question from a patient about, well, does everything I need to purchase have to be organic? I say to the patient, no, not everything has to be organic. And you see that there is a real discrepancy in price too. And I think that when we have to consider that. And so I generally recommend to a patient if the cost is a factor too, then maybe as long as you're getting the vegetables, maybe that's the more important part to this as well too. But we're not seeing enough data here to be able to make a recommendation that you have to eat organic foods only. Okay. Okay, physical activity and exercise. You're all here for the physical activity and exercise part. So we're really trying to emphasize 150 minutes plus per week of moderate to strenuous exercise. That's what we want to try to achieve. Why? Because we actually have really great studies that show when patients achieve 150 minutes plus a moderate strenuous exercise, that they reap benefits compared to patients that don't. That they live longer in ways that we can't even understand, aside from, for example, the cardiovascular benefits. So we really want to emphasize getting out there and being active. And then you may ask yourself, well, how do I know if it's moderate or strenuous? So the way that we figure this out is you've heard of this company called Orange Theory. Orange Theory, so they emphasize this idea of color zones for your heart rate, that for whatever reason, 65 to 75% is denoted as orange. I notice on my Apple Watch, when I exercise and my heart rate's in that 65 to 75% range, it shows as orange. I'm not sure why orange has been designated that. But if you're getting to 65 to 75% of your target heart rate, and we'll talk about how to figure out our target heart rate, that's at least getting to moderate level activity. It's at least getting a moderate level activity. But to be honest, if that's hard for you to figure out, I think if you're feeling you're breathing faster, you're sweating, you're feeling a workout, I think you can trust your body that you really are getting to that moderate level, that you are getting a good workout. So we take 220 minus our age, that's our maximum heart rate. And then we do 65 to 75% of that. And that's how we know what heart rate we're trying to get to be in that orange zone that is supposed to be most ideal to get to that moderate level. And you want to get 150 plus minutes per week of that. So you're not necessarily counting the warm up. If you're warm up 30 minutes and you're going at a leisurely pace, that may not be something you want to count. But you know what? Any exercise you do is really beneficial. for 1 minute of exercise, any type of exercise, for 1 minute, you add 5 minutes to your life. You add 5 minutes to your life. And when you do moderate strenuous exercise for that 1 minute, you add 7 to 8 minutes to your life. That adds up. That really adds up. Where does this data come from? It comes from really good work out of Stanford, looking at exercise physiology, coming out of their division of cardiovascular medicine, really demonstrating this. So for every minute of exercise, if it's just like walking, we're adding 5 minutes. If we get to the moderate to strenuous, we're adding 7 to 8 minutes. So anything you're doing as far as activity is helping you, but you might want to maximize it as much as possible if you're out there anyway. Okay, and the other thing we want to emphasize is doing not just one type of activity, that we find that there's cardiovascular benefit through a variety of activities. Doing yoga is really beneficial. Working with weights is really beneficial. Working with the treadmill, the bicycle, all of that. I would really encourage all of you to have diversity in the things that you do and not just do the same thing. Because the last thing we want is for you to develop an injury from repetitive movement that puts you out of commission for a long period of time and then makes you sedentary. You know how hard it is after you have an injury or a long period of time where you haven't exercised to get back to the exercise. So it's really important to have diversity in terms of activity. You don't feel like just because your heart rate is not going up the way it does when you go for a run, that there's no benefit. There's definitely a benefit. Okay, so stay as active as you can be. And so when you have a program like this is wonderful. You have people here that are guiding you to push you to get your heart rate to where it needs to be, but also making sure you're not pushing yourself too hard. So we have to call the paramedics as well too. We want to do this in very careful fashion. So this is a really special program. It's a program, again, where I'm ashamed to say to you that I wish I'd been here sooner. But what I can say to you is I have many patients that I've told to come here. In fact, some of my patients are here today. And so it's really great to be here today, to see those individuals. Any questions about that? Anything that I can answer for you here?
One more question on here was about the impossible meat.
Yeah, what a great question. That if you look at the contents of these impossible meats, you might find that actually there are plant alternatives that do have saturated fat in them. And so what we would say to you is if you totally try to replace your meat with impossible meats, that may not be the best option to totally replace it with impossible meats. You may have to come to the conclusion that you just have to have an alternative to meats, that is vegetables. Maybe. Okay, stress management and mental health. So we know that chronic stress does raise blood pressure. It does raise blood pressure. And so when I have a patient come to clinic and they say, well, doc, yeah, my blood pressure's up, but I just had stress. It's just stress. But if we're chronically stressed, that means our blood pressure is always up. That's not a good thing. And so as a cardiologist, if I'm not addressing that aspect of a patient's care, I'm not providing them with the excellent care that they deserve. And so this again emphasizes the idea of being holistic. We talked about this with the broken heart syndrome. So it's really important that you take steps to make sure that you are in a situation where you're minimizing stress. And so minimizing stress is coming here, interacting with the people around you, interacting with this program, doing exercise, but also taking the time to watch that movie, spend that time with that family member. We really want to emphasize that. Doctor's orders that you need to enjoy your family and minimize stress. There's so much stress in the world, in our lives, and it's really important that we address this. I even have patients that'll tell me or experiences maybe in my own family where my kid will say, I'm not stressed, Dad, I'm not stressed. And then he gets teary-eyed as we're talking about not being stressed. But the reality is that we carry a lot of stress that we may not be aware of. And so I think it's really important to take that mental check with ourselves, to acknowledge it's okay to feel stress. It's okay to feel stress. Our body has been devised to be able to have this stress response. But when we have the stress for too long, it's not a good thing. And so remember that you're not alone. That's like, again, this concept of community. That's why this program is really great, is that it reminds us that we're connected. We're all part of the same family here in Sacramento. So don't ever forget that. So stress meditation techniques, or management techniques rather, does include meditation, mindfulness, this idea that we're taking time to clear our mind of all thoughts, that we're just in this area where no thoughts are entering our mind, that we're just focused on our breathing, for example. That's what we describe as mindfulness, just in the moment, no thoughts entering our mind, and we're just focused on our breathing, for example. It's a very hard thing to do. It's a very hard thing to do. And so if you haven't done it, I really encourage you to consider it, because it might get you to another level that you may not have realized you can get to. And then we talked about this idea of holistic cardiovascular care, that while we're treating the heart, we're not forgetting about the mind, the other parts of the body, that we have a team that involves the endocrinologist, the kidney doctor, the patient, their family, their children. It takes a village. It takes a village, as you know. Okay, and we're gonna wind down here, because I really could talk forever when it comes to interventional cardiology. And so what we want to say here is that nowadays, when a patient comes in with a heart attack, we're able to use minimally invasive procedures to be able to access that artery and open that artery up. And so it's not per se a surgery. And so I feel bad. I'll always tell a patient, they'll say, well, doc, when is that surgery going to happen for me? I'm like, it's not a surgery. It's a procedure. We're not cutting you in any way, but I understand as a patient, you may perceive it the same way, because it's high stakes. It is very much high stakes, where there is a risk of even death with these procedures. But the reason why we do these procedures is it's clear that the benefits of the procedure outweigh that risk. We have the opportunity to intervene. We have the opportunity to open up that artery, save a patient's life. And time matters. So we want a patient having a heart attack come into the hospital right away. And why does time matter? Because of the fact that you can have damage to the heart muscle if we don't act quickly. And so we want a patient to come in, want to put in that stent, open up the artery. I'm sorry, I'm talking as though you're all familiar with a stent. A stent is a device that's used to open up the artery. Basically, a stent is in a closed fashion here. It's around a balloon. We implant it in the artery precisely where we want to. We have to put it within millimeters, and we expand the balloon. The stent gets implanted into the artery, and it stays there for the rest of your life. It can re-narrow, but we don't take that stent out. We put in a stent within that stent. And sometimes when patients have recurrent stent procedures, we have to think about doing an open heart surgery where we bypass the blockage, But when a patient has a heart attack, we got to move really quickly. And sometimes doing surgery is not the best option in that scenario. And so what we're trying to prevent is a condition called heart failure. We're trying to prevent weakness in the heart muscle. And that's a really important issue, because the number one reason for hospitalizations in our country is heart failure. And so we have to work hard to prevent it. So there's different types of heart failures we talked about. There are different types of heart failure, as we talked about, but it's really important that you remember that if you're having any symptoms that suggest you're having a heart attack, that you get into the hospital right away. If you have high blood pressure, that can result in stiffening of the heart muscle, and over time, over months to years, that can also result in the heart muscle weakening or also making it really stiff. And patients can start to have signs of heart failure in that scenario. And so it's important not to ignore the high blood pressure, not to say, oh, it's just stress. If you're stressed all the time, it's always high. It's really important that we think about that issue and we really address it. Another thing here is that we have really advanced techniques now where we're not just injecting dye into the artery to see the blockage, that we're able to, at a level of resolution that's really amazing, 10 microns, really see inside the artery. We're able to visualize the plaque. We're able to understand, well, this heart attack was due to, yes, plaque rupturing, or eroding. And now we're learning about how in different populations it can be different in terms of this erosion or rupture process, and it can target therapies. So we can be more precise. There's this term called precision medicine, which refers to the idea that we're not just cookie cutter in the treatments we provide to a patient, that for a given patient in front of us, we try to provide them with very specific therapies to benefit them. And then patient education, it's so important. We just talked about earlier today about the idea a patient comes with a heart attack, we put in a stent device, they get to go home the next day, but we need to educate the patient that knowledge is power. And by more knowledge we impart to a patient, the more so they'll understand why they need to do the things that they need to do. The diet, the exercise, taking their medications. And so it's very, very critical. Also an intervention, yes.
I don't hear much about pacemakers anymore. Are they still doing pacemakers?
Yes, we're still doing pacemakers. And so that really relates to the electrical system of the heart. We talked about arrhythmias being an issue, abnormal heart rhythm. So yes, we are doing pacemakers. You're probably most familiar with the pacemaker being implanted into the chest wall with leads going into the heart. Now we have what are called leadless pacemakers, where the battery doesn't have to be implanted in a chest wall. It's like a USB drive, a really small little device that we implant right into the area of the heart that needs to be paced. And so that's a really great option for patients as well too. So the technology there is really evolving. The whole space of cardiovascular medicine is really evolving. So great question. Yes, we do have pacemakers. They will always be needed because unfortunately we will deal with conduction issues. And now we have small miniature devices available.
How
I
many
was-
stents do you put in a week?
I'm sorry?
How many stents do you put in a week? You do
How many
that-
stents I put in? It can be very variable. It can be a lot. It can be a lot of stents in a week. I would maybe better able to answer that question as a group between my colleagues because I'm not there 24/7, but we all work long hours. But tease you with that. So probably in a given week, we must do at least like I would say 30 to 40 stents. So it's quite a bit. Patients coming in with heart disease, unfortunately.
I was just wondering if someone comes into the emergency room or to the hospital with a heart attack, how long from the time they get there until you or one of your colleagues is doing stent?
Yeah, so it depends on the type of heart attack they're having. If they're having what we call rip-roaring heart attack, ST segment elevation myocardial infarction, we have a metric system where from the time they have first medical contact, from the time they meet the ambulance to the time we open the artery, it's got to be within 90 minutes.
Wow.
It's got to be within 90 minutes because of that idea that time is myocardium. We got to open up that artery as soon as possible. Patients can have other heart attacks where we don't have clear-cut data yet that taking to the catheter right away is necessary. But we'll probably develop that data. I think over the last 20 to 30 years, we've seen that taking patients to the cath lab to have this procedure done, the stent procedure, is better than just focusing on medications alone. That's very clear that if we review our what are called guideline statements that tell us as doctors what we should be doing, they're very clear that putting in a stent in this situation is more beneficial than focusing on medications alone. Can you believe that we can also put in a new heart valve from an artery in the leg and a patient can go home the same day? They can go home the same day. So we have what's called a transcatheter aortic valve replacement. So we talked about the aortic valve and we talked about aortic stenosis and narrowing. And so with the appropriate planning with the CT scan, we can get all the measurements, we can decide what size heart valve a patient will need, and then we can access that artery. And then I'm being really crude here, it's like a valve on a stick. It's not quite like that, it's a very flexible device, but it's going all the way up, around and into that valve position. And like that stent, although this is a little bit bigger, we inflate a balloon and the valve expands to the appropriate size to treat that valve. And then we have what are called balloon expandable valves. I'm sorry, that was an example of balloon expandable. We also have what are called self-expanding valves, where it's like a flower where you slowly kind of release this cover and it opens up and it stays in place.
That's a cath lab procedure, it's not a operating room procedure.
I'm
Do
sorry.
they go to the cath lab or do they go to the OR and have it?
Oh, yeah, so we have what are now called hybrid labs now. So it's not quite a surgery, it's not quite just a cath lab. So we have these hybrid operating rooms where we share this procedure with the surgeon. It depends on the hospital, whether the surgeon might be more involved than the interventional cardiologist. At our institute at UC Davis, it's more the interventional cardiologist, but it is a team. It's a team. I'm all biased too. But it's definitely a team, to be able to accomplish these procedures safely. Say that again?
The surgeon is there too.
The surgeon's there too. We need surgical backup because there can be complications can develop. But thankfully, this technology has really evolved where clearly it's a very safe option. Yes, another question.
Big cow.
Yeah, so we use pericardial tissue. So that's tissue that comes from around the heart. And so we use that to formulate the heart valve. And so we'll get that tissue from cow or pig. Both have worked well. And yes, we're still doing that. We haven't come up with a synthetic material that works better than that currently. So with this material from pericardial tissue from a pig or cow, we have these valves that we're able to implant that last like 15, 20 years sometimes in given patients. Yes.
Like, after that.
Yeah, well, that's a really great question that we used to do these procedures almost exclusively from the groin, the artery in the leg. For valve procedures, we still need to use the artery in the leg, but now for stent procedures, we can do everything from the artery in the wrist. And the advantage of that is that if we're working on the artery of the wrist, the same day they can get up and walk around. And so, yes, they could start cardiac rehab in theory the same day. We don't typically do that, obviously, for practical purposes that we want to just make sure a patient is doing well after a stent procedure. And so generally the practice is that a patient would probably not start rehab for 1 to 2 weeks after.
Part of that is someone who to get sent in place today. Would they be able to even surpass what their heart was able to do before, or this would be kind of the same level of physical activity as they were before?
So the question is, after a stent is placed, could they surpass what they're able to do beforehand? And so it's a tricky question to answer. So certainly if a patient before they had blockage in arteries was able to do a certain level of activity, when they develop these blockages, they slow down. They're not as active. And so for some people that develops over months, for other people it can develop over a year. And so then they get a stent procedure done. And so they're not going to be able to instantly be able to do what they were doing before. And so that's why, again, this program is so important, that this allows them to build up and get to where they were previously. And so, yes, patients might be able to exceed what they're doing before when they're really committed, and depending on various circumstances. Yeah, so the field of interventional cardiology, cardiovascular medicine is really exciting. This is just mentioning to you that the slide is really trying to emphasize the idea that this area is evolving very rapidly. We talked about how we have technology that allows us to give really detailed imaging inside of the artery. Not only do we have stents, now we have what are called drug-coated balloons. So we're not only putting in stents that we can actually inflate a balloon that can put drug into the blood vessel wall that can help keep that artery open. We might think about that in a scenario where the stent is too big for the artery. We can only put in stents in arteries of a certain size. So this expands the options available for a patient. And there's obviously ongoing research and education taking place at UC Davis, like it is at hospitals and universities throughout the world. Okay, conclusions and a call to action. So I think we really emphasize the idea.
Small conclusion on a call to action, CTA.
There's the AI answer to that. So sorry. So yes, a multifaceted health approach, right? We talked about the idea that we need to focus on his therapeutic lifestyle with diet and exercise. We talked about education being really important here. And we talked about how we need to continue to work towards advancements in this area, and that's ongoing. And we also talked about this idea of community engagement, really emphasize the idea that while in this world we can often feel alone, we should not feel that way, particularly in our community of Sacramento. And that's why a program like this is, again, so special, that you're seeing each other on a regular basis. You should say hello if you're not, I'm sure you are, and help one another that way, give each other encouragement. And me being here is just proof that at UC Davis that we very much care about our community, that we care about you. We're here. I wouldn't be here unless I cared about where I live, the people that I serve. And so we just want to remind you of that. And again, this program is just such a great interface with that between UC Davis and other hospitals in the area and you as a patient and where we live. And then program opportunity. I'm sure I shouldn't be speaking to this, but I was going to say, I'm sure with this cardiovascular wellness program, there's a lot of opportunity for all of you to help contribute in ways that you find meaningful working with the leadership here. I feel very fortunate to be able to spend time here today with you. I arrived a little bit late. You all listened to me very attentively. You asked really wonderful questions. I really appreciate this. I think I'm prepared now for the toughest patients possible. So thank you so much for that preparation. But I hope to see you again in the future. It was my pleasure to be here today. Thank you again.
I'm sure Radhika warned you about this group.
She did. I thought it would be well, no offense. We have students here, but sometimes the students can ask really tough questions. But no, you guys asked great questions. But I have to say, the patients asked pretty tough ones.
Thank you so much for joining us. And how it's sad is this is a great program. We do awesome stuff and we are unique, and that's what's sad. It's like every educational entity should have a program. Every university that's next to a hospital.
Yeah, absolutely.
They don't.
Yeah.
Yeah, we're just blessed. We know we're blessed. What do you think of our space?
Yeah, this I didn't even realize it's so close. It's I'm glad to be here. Thank you so much.
Great talk, Doctor. Thank you. I want to tell you the rest of the story about trigeminal neuralgia. Do you remember doing the assessment?
Yes.
So 100% relief. 100% gone off the medicines with that. I literally have a new lease on life. So great. I feel the best I